Has started. Thank you. Over to
Okay,
you.
so that's the first slide, which just tells you the title of the talk. As I say, I retired from King's. I was team leader for the tongue tie service for 11 years. So that's just what that slide's about. So if you go to slide 2. Okay, so tongue tie is a midline anomaly. It occurs around about the 7th to 8th week of gestation. At that time, some programmed cell dieback should occur and the tongue should peel itself away from the floor of the mouth. So in tongue-tied babies, that doesn't happen, and the tongue remains tethered to the floor of the mouth either by a diaphanous, stretchy, see-through membrane, or that's for anterior tie, but for posterior tie, it's a midline fibrosis. So it's a tethering of the tongue with some submucosal tissue. Okay. Their incidence is 2 to 1 more common in males. Okay. 1 in 7 babies will have some kind of frenular tissue. We've all got frenular tissue. It only becomes a tongue tie when it affects your baby's ability to mobilize the tongue in the way that's necessary for breastfeeding. There is a strong familial tendency, so you'll most likely find families where siblings or parents have had tongue tie. We get criticised a lot for, oh, you know, tongue ties are fad. In actual fact, it's been around. You know, it's mentioned in the Quran, the Bible, that kind of thing. And people say, oh, we didn't have it in our day, but perhaps our diagnosis is better. We can diagnose parents more readily, but we still get very, very many babies with undiagnosed tongue tie and feeding problems. There is a question about folic acid prophylaxis. I'm doing a PhD at the moment on this subject, and obviously it's going to be a long time in the publishing, but there is a school of thought which is as yet unevidenced that you know, the use of folic acid beyond the first trimester may or may not interfere with that apoptosis process. So it doesn't, you know, it's useful, folic acid, for preventing major midline anomalies like spina bifida and ancephaly, but maybe that's just my thought and my opinion, which obviously is not evidenced yet, is that it does too good a job and prevents that sort of cell dieback, allowing the tongue to free itself from the floor of the mouth. Okay, slide number 3. So we get a lot of misdiagnosis. We see a lot of babies who've got frenular tissue. They've either been told it's a minor tongue tie, it's a little tongue tie. I really sort of despair when I hear those words because it throws mums into panic. Most babies will have a degree of frenular tissue, and as it says on the slide, it only becomes a tongue tie when it restricts the tongue mobilities necessary for breastfeeding. So the baby does need to elevate properly, lateralize, move the tongue from side to side, and protrude the tongue persistently over the lower gums. Not all tongue ties require treatment. Treatment should be preceded by adequate feeding assessment, you know, 1 or 2 assessments with a view to, you know, reassuring the mum that her and her baby are safe, her milk supply is safe. If she expresses or feeds the baby with a nipple shield, there's a lot that can be done. This shouldn't be a mad rush to treat the baby. Okay. Slide number 4 is about variants of tongue tie. Okay. So as I said before, we shouldn't assess the tongue tie on visual assessment alone, okay, because many babies you see with frenular tissue, they can move their tongues perfectly, and that's evidence in the feeding assessment. You know, I weigh babies before and after a feed. I explain all the behaviours during the feed, so mum gets to know how her baby feeds. So grading severe, moderate, mild relates only to the mobilizations that the baby is not able to make. Okay, it doesn't relate to the position of the frenulum. You can have a frenulum that goes right to the tip of the tongue and the baby be able to feed perfectly. You can have a frenulum in the photograph which is maybe tethering 25% of the tongue, and the baby won't have the necessary mobilizations at all. So we should be careful when we speak to parents about tongue tie. Okay. Yes, so number 5 is, just got to find my notes. So posterior tongue tie, that often gets misdiagnosed. It's often difficult to see. You don't see a clear vertical membrane. You may see a vestigial white line on the midline. It's only really palpable via the lateral sulci. So those are the 2 pockets either side of the midline underneath the tongue. And then if you put your finger, you know, digitally examining the baby, you do need to put your finger in quite far up to the first crease in your index finger and then do a lateral sweep. Okay, and you'll be able to feel it if it's present. If you put your finger on the midline, on the band of tissue, it will dimple the dorsum of the tongue. Okay, the tongue is one muscle, it's the genioglossus muscle. So if you put pressure on any frenulum, it shows that it's tethering the tongue by the flat surface of the tongue dimpling. I put a little note on this slide that the baby has some perioral bursa, you know, sucking blisters on the top lip, and that's often because instead of the tongue stabilizing the nipple inside the mouth, the lips have to. It's an adaptation that the baby has to make. So the baby stabilizes the nipple on the midline of the buccal cavity by using the lips and the gums, which is quite painful for mum. Okay. Next slide, please. Okay, so parents often get very worried about upper lip tie. Okay, there is no peer-reviewed conclusive evidence for treating a maxillary tie. In all my practice of 30 plus years, I've never ever seen a lip tie causing a problem with feeding. And the advice from the most senior orthodontist at King's Dental School was that we should leave these alone, because as the baby grows, their face grows and head grows in, you know, several dimensions, and that lip tie tends to retreat. Sometimes they can break spontaneously with toys or cutlery. Some babies have a diastema. That's where the lip tie divides the gum, and you know, there is a potential for gapping of the teeth, but that could be, I don't think there's any evidence that removing that prevents that happening. So usually it's treated with orthodontics once the deciduous teeth have gone. Okay. So if there is a problem with the top lip during feeding, the top lip never needs to be rolled right back. You'll often see that in photographs of correct position and latch. It doesn't need to do that at all. You just need to lift the lip by putting your finger in the nasolabial fold. That's a little fold beside the nose, beside the nostril, and just lift the lip into a neutral position. Okay. Slide number 7. Okay, so when you're looking for tongue tie, you need good resources. You need the baby to lie down flat. There's no good sitting the baby up or having the baby in the mum's arms. It's best to lie the baby down, have a good light. Make sure you've got gloves, non-latex gloves, and some tongue depressors, because you'll need to induce mobilization of the tongue with your gloved finger, and you'll need to lift the tongue up. Okay, and slide number 8. So the assessment should include how the baby is able to move the tongue. There are several assessment tools. There's the Hazel-Backer score, the Tabby one. There's quite a few, but each of these assessment tools has their difficulties. So the tool that we use at King's is just going through a checklist of assessing various features inside the buccal cavity and looking at how the baby mobilizes the tongue. Okay. So as I said before, frenular tissue can be very thick and fibrous and restrictive. It can also be quite thin and see-through and non-restrictive. Some tongue ties are joined to the tongue, and we call that a lingual attachment. And many tongue ties, anterior ones, have gingival attachments, so they're attached in 2 places. And I often refer to those as double tongue ties. So in the picture there, I'm isolating. I've put both my index fingers, so you can do this if you're assessing a baby or looking for a tongue tie. You need to have baby lying down. You need to put both your index fingers simultaneously under the tongue, either side of the midline, and you'll be able to isolate the anterior tissue, and you can then assess how much of the tongue is left untethered. So it looks in that case that the picture maybe 25% is untethered, so we would say that's 75% lingual attachment, and you can see that the frenulum is quite short and tight because it's tethered to the gums, and that's a gingival attachment. And that often, parents will often say the baby doesn't open the mouth wide, and it's quite difficult for baby to open the mouth wide for latching when there's a gingival attachment as well. Okay, next slide, please. So elevation, during crying, the tongue should elevate to the palate to protect the airway. So with tongue tie issues, in this picture, I'll just show you that you can see clearly that this is an anterior tie. It's quite thick. It's joined to the tongue and the gingiva, and you can just see it's transected on the horizontal axis by the salivary tissue. Okay, so just as an additional thing, when you divide a tongue tie like this, you divide the superior frenulum. Okay, so that's the portion of frenular tissue between the salivary cornua, the salivary ridge, and the tongue. So we do see quite a few that have to be revised surgically, where either the salivary cornua has been divided, which should never happen. Yeah, so that's just a little additional thing. So what to look for? When a tongue elevates correctly, the dorsum of the tongue, the middle of the tongue, should elevate without dimpling. And the lateral edges, the side edges, and the tip should all elevate simultaneously. So when the genioglossus muscle, the tongue, is held down, you'll find that only the side edges of the tongue, the lateral edges, and the tip of the tongue will only be able to elevate, forming a sort of lily pad appearance. Or alternatively, just the lateral edges, the side edges of the tongue will elevate, making the tongue look a bit like a whale's tail. Okay. And again, if you put your finger, you know, you can assess how much of the tongue is tethered. Okay. Next slide. Got a blank one. Lateral movement. Okay. So when the baby breastfeeds, the tongue needs to move in a rhythmic, wave-like manner. Okay. Bottle feeding is quite different. The tongue and jaw only needs to move. The tongue remains on the floor of the mouth, and the jaw only needs to move up and down. But in breastfeeding, the tongue needs to move in a peristaltic wave-like motion from the tip of the tongue back. Peristalsis in the gut is initiated by sucking in the mouth. So often, very often, babies with tongue tie present with reflux symptoms, and that's due mainly to disorganization of the peristalsis or aerophagia, eating air, which is accompanied by loud clicking with the tongue as the tongue loses suction. Okay, so lateralisation, all you do is you put your finger on the gum and get baby to point with their tongue. This is an innate reaction. If you put your finger on the lower gums, baby should be able to spontaneously point with their tongue to your finger. You don't want the baby turning the head to point with the finger. It should be with the finger. So you can observe how the baby moves the tongue from side to side. And what we want is a nice, crisp, ready reaction where the tongue moves in a horizontal plane. Okay, so in babies who have tongue tie, their lateral movement may be asymmetric. They might not be able to lateralize on both sides. There may be lateralization may be absent, or most likely what you'll see is that the baby tries to lateralize, move the tongue from side to side, but the tongue distorts by twisting and standing on its side. So that's all about lateralization. Okay, next slide. So protrusion is the main function that the baby needs to feed. Okay, it needs to persistently protrude over the gums during feeding. Okay, if the tongue is not able to do that, suction will be lost. Internal negative pressure in the mouth will be lost. The gums will be uncovered throughout the feed, and that leads to trauma to the nipple, because it will only be the tongue compressing the nipple that raises a blister, which very quickly breaks down into a wound, and that needs looking after. Okay, so when you're assessing suckle, you're assessing how far the tongue tip can come over the lower gums, the alveolar ridge. So in tongue-tied babies, it may not come over at all. It may remain behind the lower gums. If it does protrude, it may be tip only, and then it will snap back because the tongue will be under tension from the lingual frenulum. So it'll just come out a tiny little bit and then it'll immediately retract. So this results in aerophagia, the baby eating air, the feed being fractured, the baby not being able to maintain latch, the baby feeding poorly, baby sleeping poorly, mum sleeping poorly, and I'm sure you know the sequelae of the mum not sleeping. Okay. Also, when you're assessing suckle, you're assessing how organised the suckle is, how rhythmic it is. Some babies, they do tongue thrusting. If they're tongue-tied, they may push the tongue from side to side, and obviously that's not helpful for breastfeeding. Okay, next slide. So while we're in the mouth and around the baby and the mum, we should look for other pathology, because a lot, you know, the main indicator, one of the main indicators for treating a tongue tie is maternal pain. Okay, so we should look for other pathology, thrush being the main one. So you can see there's a picture of oral thrush. If there's oral thrush in the baby, you need to look at the mouth. So generally, thrush on the breasts presents as hypopigmentation of the nipple and areola. So the brown, the colouring pigment kind of goes, and you'll see a change in colour of that tissue. It's very, very sensitive to clothes, towels, the shower, picking the baby up. Okay. So if you see thrush, it's a good idea we would look for other vectors in the mother and baby. So perianal thrush is very common, nappy rash, cradle cap, thrush in the axilla, in the neck folds. So we should treat all the vectors simultaneously. Okay. Sometimes you see in the mouth mucus retention cysts, particularly in severe tongue ties where the tongue is in very close contact with the floor of the mouth. It's just that the mucus can't escape the ducts and it forms a little cyst. And rannulas are another sort of cyst-like structure on the floor of the mouth. So, you know, we would arrange for treatment. Yeah. Okay, next slide. Okay, so the moment at the tongue tie clinic, as I understand, it's due to COVID and social distancing, and they haven't been able to see the numbers that they have been seeing in the past. Okay, so we just hope that that's going to get better. Our clinic in Croydon, we see 6 babies on a Saturday. We see them 90 minutes apart. So, you know, it's all sort of COVID compliant, and we wear dental grade PPE, that kind of thing. So we treat babies. So what we do in the private practice is the same at King's. We treat babies from day 8 to 26 weeks. And the reason we treat babies from day 8 is that we want an adequate maternal milk supply, so that baby goes to the breast, gets rapid analgesia, and we achieve hemostasis quickly. Also, the other risks of the surgery are recurrent tongue tie. It's very important that the baby goes to the breast every single feed before you give a supplement if necessary, so that the tongue moves in the right way and prevents the edges of the wound adhering to prematurely. Okay, so don't offer frenulotomy as an elective procedure about parental concerns for speech and language. There's no peer-reviewed evidence as to, you know, having a tongue tie in infancy would definitely or definitely not cause a problem in the future with speech and language. We don't know. And there is a referral pathway. So you can go on the King's website, Tongue Tie Clinic, and have a look at the referral pathway, which I will go into in a bit more during this talk. But there is the referral form is on there for you to download. Okay, so referrals are from breastfeeding specialists generally, so that's community infant feeding practitioners, health visitors, midwives, lactation consultants. Okay, number 14's next slide. Okay, so I think this is where this is the referral pathway. So often parents are told on the ward or early in the postnatal time that your baby's got a tongue tie, and that just throws parents into panic. Okay, they feel that they have to have it treated immediately. You know, that's going to cause a problem in the future, and we need to reassure parents that you know, with the right help from, you know, the breastfeeding support people, that milk supply will be protected. The baby will still get sufficient calories with supplementation, and you will eventually get a surgery if clinically indicated. So we do require 2 assessments. One maybe on the postnatal ward that would be given with the discharge plan, and that plan would need to be reviewed in a few days, and then another plan written, and then the referral can be made. Okay. Next slide. This is just an algorithm of the tongue-tie referral pathway. Okay, so it's important to give parents a clear feeding plan, okay, to ensure the safety of babies' nutritional intake, and then that plan, as I said before, needs to be reviewed and a decision made whether to refer the baby to the tongue-tie clinic. So the feeding plan should include attainable targets. Often I see parents who've been given unattainable targets by practitioners, which often leads to difficulties with their mental health. It would be feeding the baby, expressing the milk, supplementing, avoiding bottles and teats, and nobody's spoken to them about finger feeding. So we do need to make it as easy as possible for parents. There is on the referral form, if you have a look at it on the King's website, it's a checklist that before referral, those things need to be in place to get the best outcome for mother and baby. Okay, next slide, please. So this is a poster that we made for the wards at Denmark Hill and the PRU. It just advises staff what to do, so that mum goes home with a clear plan. She knows where to and how to get it reviewed. She knows the pathway, so she has some assurance that things will be okay. Next slide. So at King's and in the private practice, we only treat if baby is frenulotomy ready. So the baby can be referred, but if the baby's not quite ready, if the dyad's not quite ready for the surgery, we will help them in clinic to get ready for the surgery. So if there's a problem with milk supply, we'll assess that by pre and post feed ways away, and maybe prescribe some galactagogue medication. We would look at how they're expressing, that kind of thing. So the baby does need to have sufficient experience at the breast before the surgery. They need to be either feeding at the breast with or without a nipple shield, because the minute we do the frenulotomy, that baby is not instantly going to know how to breastfeed. It's important to note that frenulotomy is not an instant fix. We need the baby to have had experience to breastfeed, so we can put the baby to the breast immediately after the surgery, achieve hemostasis, and the baby get analgesia from the complex sugars in the milk. Okay. The first week after the surgery and before, if the mum still needs to supplement, we do want to avoid the potential for teat and flow preference for bottles and teats. So anybody getting dyad ready would need to show the mum how to finger feed. So it's not as onerous as it sounds. It's simply you put an NG tube on your finger, the other end goes into the bottle, baby sucks your finger. So we are mimicking with the finger feeding the same kind of action that the baby would use at the breast. You need to avoid cup feeding in tongue-tied babies, because cup feeding in a tongue-tied baby can be quite dangerous, because babies need to extend the tongue and lap the milk from the cup. Okay, so they can't really do that. They can't, you'll find parents pouring the milk into baby's mouth, and that results in pooling of the milk on the floor of the mouth and a risk of aspiration. We do require that the baby is having 50% or more of its milk from maternal milk supply, and that's calculated on that calculation there, which is the calculation for breast milk, breastfeeding, or combination feeding. Okay, next slide. This poster here just kind of is for the ward and the community, how to get the baby ready for the surgery. Okay, so it's my view that to do a tongue tie surgery without those things being in place is quite hazardous to milk supply. You run the risk of recurrent tongue tie and not get the best outcome from the surgery. Next slide. Oh, okay, so this is about the form. It tells you some of the things that you need to include. It's all very self-explanatory, the form, actually. You can complete it online, you download it and complete it online. So it's just go through the form and fill in the details. Okay. Next slide. So this is what happens to the referral when it arrives at the tongue tie clinic. Okay, every referral is triaged by either lactation consultant or paediatric surgeon, because we have, you know, very many referrals, and we want to make sure that patients are ready, that there's not an expectation of having it treated and they're not ready when they come, and then we have to write a feeding plan and get them ready for the surgery. So that often can be quite disappointing. So we should do, you know, if we're referring, we should make sure that the baby's ready for the surgery. Okay. So you can see review the referral, allocate an appointment, okay, or ask for more information. Unfortunately, the waiting time is longer than 7 days at the moment, because before COVID, we'd have 3 clinics a week and we'd see 10 patients in that clinic. You can only see 3 or 4 patients at a time now. So the wait time is quite long at the moment, anything between 2 and 6 weeks. So the mum and the parents, they attend clinic, they complete a pre-surgical form, and they're given a group presentation or face-to-face presentation about the risks, benefits and alternatives to the surgery. They're then seen in clinic, they have their consultation, we do the assessment, decision to treat or not. Sometimes parents, they're unsure about having the surgery if it's clinically indicated, so it's absolutely, they can come back another day. The frenulotomy is performed after consent, and they're discharged back to their referring team with a feeding plan and information on how to manage the wound and scar after the surgery. Next slide. So this is me doing a frenulotomy. In our practice and at King's, we use the instrument being used is called a Brody director. So you lift the tongue up, put the frenulum on stretch, isolate the tissue in that little slot. The paddles of the instrument, they look a bit like Mickey Mouse ears, protect the sublingual blood vessels and the tongue from division by the scissors, because if you divide the blood vessels, the sublingual vessels, and if you divide the muscle, you will get a bleed. Okay, so we use curved strabismus scissors, blunt tipped ones. Okay, We don't use a general anaesthetic. We used to use teething gel. I'll go into that later, but the regulations around that changed in 2019. But we do use paracetamol for babies over 8 weeks old, and we achieve hemostasis by breastfeeding alone. Okay, very occasionally we may need to apply some pressure, but that's why we want the baby to have experience of breastfeeding with or without a nipple shield. Okay, the whole thing, the whole surgery is very quick. The baby would be away from the parents for maybe 2 to 3 minutes. Most of that time is swaddling the baby because we want to keep the hands away from the face. The baby is held by the assistant in an intubation type hold, and then we go in, lift the tongue up and divide the tissue. We need to get a sublingual rhomboid. It's not a frenulotomy until you achieve that. So you, whether it's posterior or anterior, it's the same surgery. So that bit, actually treating the baby, takes about 30 seconds. Baby's unwrapped, gauze is placed in the mouth, and baby returned to the mum, and help is given with feeding. Okay, next slide. Yeah, I forgot to say, there's very few people that use a Brody director in the community. Most people would use just their fingers to lift the tongue up, but I think it's much safer. You get an accurate procedure, you isolate the tissue, you don't divide structures that you shouldn't divide. Okay. So as I said before, when parents arrive at the clinic, they get given a talk, then they get the aftercare sheet and the feeding plan on discharge. And there is telephone support for parents and referrers. In our practice, private practice, parents can contact us any day of the week from 8 AM to 7 PM. We can FaceTime them. Usually their queries are about baby not wanting to feed after the surgery. So we do explain about wound guarding. Obviously, there's a wound underneath the tongue. If you scaled that up to an adult size mouth, it would be quite large, and baby will wound guard. You know, they won't want to move their tongue very readily. So for some parents, you know, we warn them that will happen. They will be sore with the wound care, the additional wound and scar management. We advise them about analgesia, maybe give some breast milk before you do the wound care. There's all sorts of strategies we can use, but so often parents, they are worried by that. It doesn't matter how much you advise them beforehand. It will feel like a big deterioration in feeding for the first week, and it's simply down to wound guarding and learning a new skill. Next slide. Okay, so we talk about these things to help with post-frenulotomy pain, because frenulotomy is not a painless procedure. Parents are often surprised when, you know, their baby cries after this. It isn't a painless procedure. So for babies over 8 weeks, they can have Calpol. Also, if your baby's over 4 weeks and over 4 kilos, they can have a titrated dose, a reduced dose of Calpol. We used to, in the private practice, use teething gel before the surgery to numb the area, but the regulations around the Medicines Health Regulatory Body changed the guidance on teething gel. It's now only available over the counter for babies over 3 months and 5 months, because there was some kind of Cochrane review that said that teething gel wasn't effective for teething pain. I'm not quite sure how they came to that decision, but also some parents were overusing it and some babies had acquired arrhythmias. Okay. So for babies who are the right age for the 3 months or 5 months teething gel, we advise to put on a little bit, you know, the described amount, put it on 2 minutes before wound care, and then do your wound care. Okay, next slide. This is after the surgery. We use active wound management, so that reduces our incidence of recurrent tongue tie to 1%. Okay, so not only does that involve massaging the wound twice daily for 6 weeks, it involves a review with the referrer at day 5 to 7 and day 10 to 14. So it's a review of how the wound is progressing and how the feeding is progressing, and a new feeding plan should be written and recorded in the red book. The practitioner should also assess function, you know, how baby is elevating now, how they're lateralizing, how they're protruding. If they're competent to do so, and many community practitioners, you know, they don't know or they're reluctant, if there is an adhesion of the wound, they can disrupt it with digital pressure, or they can support the parent to up their massage technique. If a recurrent tongue tie is suspected, they can be referred back to the tongue tie clinic. They have, you know, 1 clinic a week or 1 a month, where it's a recurrent tongue tie clinic where the consultant paediatric surgeon will treat any recurrence, because it's a scar, and scars don't behave the same way as frenular tissue, because they're collagen and made of collagen and not elastin. Okay, next slide. Okay, so I think people find it hard to understand that recurrence is a real problem. We treat a lot of recurrent tongue ties because the wound care, the active wound care, is controversial in the UK. It is practiced in other parts of the world. We've used it right from the start, and our recurrence rate is negligible. It is difficult for parents. We do tell them how difficult it's going to be. You know, baby's going to be quite uncomfortable for the first week, but it really makes a difference. And there's 2 pictures here. You can see the little baby picture, that the tongue will want to remodel itself. It will want to lay down that tissue again. And usually recurrent tongue ties, particularly in the case of posterior tongue ties, in my experience, it's not evidenced yet, they tend to reform in an anterior position, so can be more restrictive than the initial tongue tie. But you can see it's very thick and fibrous, and then the other one is an older child where the mum elected not to do the wound care. Next slide. So the whole aim of doing frenulotomy is, you know, under NICE guidance, is to improve feeding. Okay, and that's what we want. You know, we want good tongue mobility and good breastfeeding, if that's what the mum wants to do. Okay, that's my last slide. So if anybody wants to ask any questions.
I was going to ask, it's Aki here. I was just going to say how, just when you were talking about the kind of all the different things and the tongs and the size and the tie, all the fleshy bits, I was kind of like, oh my goodness, that's actually quite a lot to think about, really. You just think it's a tong and a little bit of, well, fleshy bit, I suppose. I hadn't realised it's probably a lot more than that.
Yeah, it is.
Yeah. And it sounds like you're very busy in terms of how many women or mothers bring their babies and
yeah, yes, we do. But you know, because we're a private patient clinic, we have a clinic on Saturday and Sunday. So Mr. Patel's clinic is Saturday, my clinic is Sunday. So parents don't need to normally wait more than a week, but we have so many inquiries, so they must be accessing other practitioners. Yeah.
It's Janet, the nursery nurse. Earlier in your presentation, near the beginning, I think it said something about that it's more prevalent in boys than girls. Is that right? And if so, is there a reason?
Well, I think a lot of midline anomalies are more common in boys, aren't they? More congenital anomalies are more prevalent in boys. I'm not sure about the etiology of that, but that's the incidence. I mean, the incidence increases just by where you are in the world, because, like, say, for example, in Brazil, you know, at the examination of the newborn, they actively check for tongue tie, which we don't do here. So that puts their incidence up, you know. But you know, there was a campaign a few years ago to make it part of the newborn check. But I think that is a bit of a double-edged sword, because yeah, it's good to identify a tongue tie and write a feeding plan for, you know, nutritional safety, that kind of thing. But also be careful, because I'd say it does throw parents into panic. You know, they think it's some kind of terrible, you know, malformation, which it isn't. It's benign, but it does cause a lot of problems, and it is easily fixed. But we should always do frenulotomy at the right time and for the right reasons. Yeah.
I mean, Catherine, I was going to ask, so in terms of you said that it's possibly due to the diagnostic criteria now that more tongue tie is coming to the fore. I mean, is it the same internationally? Is it sort of seen all over the world that tongue tie is being diagnosed more now than it was maybe years ago?
Yeah, I get that impression. I haven't done like a literature search, but you know, sort of older people, they say, oh, well, we didn't have tongue tie, you know, when we were having our babies. But I don't know if you watch Call the Midwife. They had an episode where the midwife said, oh, actually, we're going to check all the babies for tongue tie today. So it's a difficult one, because the thing is, it's not a notifiable condition, so it's hard to get statistics on it, isn't it? Or any study you would do would be like a retrospective study, so it's very difficult to get accurate statistics. But,
okay,
yeah,
and I know we're talking about in breastfeeding babies. So I know you're saying about the different mechanisms because of babies that are bottle fed. So does it not impact on bottle fed babies?
Yeah, it can do. Yes, it does. It does. So usually, if I see bottle-fed babies, they would be treated, it's my understanding, in surgical outpatients, but you know, there would have to be documented real difficulties with bottle feeding. The tongue-tie clinic pathway, and our pathway is for breastfed babies having problems with feeding, because the bottle teat acts as a prosthetic. And unfortunately, you know, we talk a lot about, we help, you know, nationally, it's a lot about the breastfeeding, but we don't actually teach parents how to bottle feed their babies. So often I will see bottle fed babies for assessment, and when you show them how to bottle feed the baby can actually feed fine. So generally it involves assessing the baby's mouth, assessing the palate, assessing tongue mobility, and then showing the mum, the parents, how to give the bottle so that the baby can take the feed. Okay, so generally that means putting the bottle teat in vertically, so you're not inducing gag. If you put your bottle in horizontally, you're likely to induce gag, and that's quite scary for parents because most parents are not aware of the difference between gagging and choking. Gagging is protective. And just gently supporting the lower jaw with the curled index finger to prevent the jaw from over-excursioning. Okay, so that you help the baby to form a tight seal around the bottle, and then pacing the feed, winding the baby, watching baby for any discomfort or stress during the feed. So those are all important, yeah.
Okay, thank you. Thank you, Catherine.
Are there any more questions for Catherine? No? Well, then I think we could probably come to an end, and just to say thank you, Catherine. That was really, really helpful. Would we be able to have your slides or anything just for record to have a look, review?
Yeah, you can have those you know, slides. I mean, if you need me to, if you've got any practice development days or
Sure.
anything where, you know, when the COVID situation's over, if you need, you know, I do have quite a few tongue tie download, you know, sorry, PowerPoints.
Yeah.
That I can share with, you know, if you want me to give any training to sort of staff teams individually, I'm happy to do that free of charge. Yeah.
Okay, great. Thank you.
Thank you.
All right
Thank
then.
you. Okay.
Bye.
Thanks, everybody. Bye.
Bye.
Thank you. Bye.